when the outbreak first occurred in middle of January, at the time it happened in Wuhan city, and I contacted my colleague there, Professor Xie Chonghua, regarding the understanding the impact of this outbreak, COVID-19, on cancer patients. And certainly with the lockdown and the curbing of distancing measures that will have somewhat impact on the delivery of healthcare services, it was important to understand what was the effect of the disease or the impact of the disease on different patient subgroup. And here we focus on cancer patients. We finally got around to the study in the end of February, when that was when things were more settled on their end. And so we embarked the study in the following manner. We designed it as such whereby we took patients who were seen at the single cancer center, and here it would be Zhongnan Hospital, and we curated about 1,500 medical records of patients, and then followed by those patients who were then subsequently detected to have COVID-19 in the same time period, and then we compared the rates of that against the rates that were reported in the community in Wuhan city in the same time period. In addition, we also looked at some of the other secondary analysis pertaining to whether treatment itself influenced the risk of getting the disease, whether treatment itself resulted in patients having more severe COVID-19, and finally, were there other factors that also predisposes cancer patients to COVID-19. The results of our study confirm a few things. One, we've observed that cancer patients indeed had a much higher risk of COVID-19 compared to the general community. Among the 1,524 records that we reviewed, there were 12 patients who were diagnosed with COVID-19, by the fact that this was based on the fifth edition diagnostic criteria that allowed the diagnosis of COVID-19 to be made, whether a PCR test was positive or the patient demonstrated positive CT findings suggestive of atypical pneumonia. Next, this increased risk amounted to about 2.3-fold higher compared to the community. So the crude incidence rate among the cancer patients in our single center was 0.82%, with an upper boundary limit of 1.2%, which is much higher than the community reported incidence rate of 0.3% in the same time period. Next, we found that among the patients who had cancer and then subsequently had COVID-19, we observed a very curious trend that the majority of patients, more than half, were actually diagnosed with lung cancer, whereas the non-lung cancer patients constituted the remaining less than half of patients. So that led us to think that perhaps a lung pathology or a pre-existing lung condition might have made these patients or predisposes patients to the higher risk of COVID-19. Now, at the same time, we observed that age was a confounder in our analysis. The majority of these patients were older, so here the cutoff for age was 60 years old. And we found that patients who had lung cancer and were older had a higher risk of COVID-19. Now, of course, the rationale for this, or one of the potential confounder for this, was that most cancer patients were indeed older or more advanced of age. Now, when we looked at the similar study that was published in the same time, looking at 1,000 over cases of COVID-19 patients in China, it was observed that age itself was not a factor for COVID-19 infection, meaning that patients who were younger, less than 40 years of age, had an equivalent risk of COVID-19 compared to patients who were older than 60. This reflects a trend not just in China, but also worldwide. And so therefore, I think our study itself is conclusive that in fact when you have cancer, it seems that you are at a higher risk of COVID-19. Now, pertaining to our secondary analysis, we observed that treatment itself was not a major determinant of whether these patients had COVID-19. In fact, less than half of these patients had ongoing treatment when they had the pneumonia or the infection. The remaining more than half of the patients actually were at the hospital for routine follow-up visits. So that led us to our second major conclusion of the study, was that recurrent visitations to the hospital appears to itself be one of the major factors that accounted for the higher risk that we saw in cancer patients. And that led us to our second recommendation in our paper, that patients, for these cancer patients, physicians should look to aggressively reduce the number of visits to the hospital, which may actually help mitigate the risk of this contracting COVID-19. Or if they have to go to the hospital, then aggressive isolation or infectious disease procedures have to be in place to avoid human-to-human transmission, and as well as patient to healthcare worker transmission. So that would be the summary of our study. Indeed, we saw a predisposition towards men. Now, of course, again, I would interpret this with caution, because like age, some of these cancer types are predisposed to certain gender. Like lung cancer, predominantly men get it more than women. So whether this is a causal association or a non-causal association remains to be determined. Now, we have since embarked on a much larger study. We do have a patient cohort of more than 50 patients now with synchronous diagnosis of cancer and COVID-19, and for which we're actually interrogating some of these factors like age and sex, as well as the cancer type more deeply to ascertain the nature of the association. Yes, so I think it's, I would like to make a few points. I think the first point is how this has galvanized and transformed the way research is being made. We see barriers being broken. We see an urgency in global collaborations. We see innovation in terms of how people work together, how people come, how international collaborations are forged to look at data aggregation, to look at answering some of these key questions that affect the patients that we see in clinic. Additionally, you can also see how clinicians have come together and come up with guidelines on how delivery of cancer services should continue in the presence of this endemic. This is quite a refreshing change, and hopefully it's a sign of things to come in terms of changing the way research is being made globally going forward, post-COVID-19 era. The next thing which I want to highlight too is it's also important to understand the downstream consequences of this pandemic in the different patient subgroup. I think our research is just the tip of the iceberg to what we need to understand the impact of COVID-19 on cancer patients. But more importantly, if you look at our data set, in fact, we observed that the number of patients who were treated or cared for differed dramatically pre-lockdown and post-lockdown. Before the lockdown of the Wuhan city, the number of patients who were treated were threefold higher than the number of patients who were treated post-lockdown. This was for a number of reasons. Patients couldn't return to the cancer center for treatment as they have traveled outside of the city before the lockdown. Two, the dissipation of medical services, given the siphoning of healthcare workers to to the infectious care wards to actually care for patients at the front line also resulted in the thinning of healthcare services for the routine clinical care, and doesn't have to be cancer, but cancer and non-cancer services alike. So that would have been affected. And three, the need for robust infectious disease protocols and containment also resulted in hospitals being affected. Hospital transmission also resulting in hospital shutdowns also cut down on the availability of cancer services. All these factors played a part in terms of reducing the number of patients or that the cancer service or the clinical service could actually cater or cater for. And this would have long-term impact going forward. And I think it's important to understand the consequence of that. And this will be a very important question to address 6 months or a year after all this is over. And I believe that the impact would be consistently felt, not just exclusive in China or Singapore, but likewise in Europe and in the US.